Jan, and thank you so much to everybody for taking the time to join the webinar today. I am a nurse practitioner, as Jan has said. I have worked in the field of diabetes since 1992 when I stepped out of nursing school. That ages me a little bit, but it's been quite a few years. I've gone from the bedside to research to universities to administration, but all in the areas of diabetes. In entering the Indian Health Service, I have gotten a wonderful opportunity to look at it from a national perspective. However, I do still see patients in clinic at the VA. I work at the Baltimore VA, and I do weekend clinics. So I'm going to share with all of you a couple of my patients that I've taken care of in my clinic. As far as my presentation goes today, I'm going to present some case studies, and I call them complex not because of the physical problems that the patients come to the visits with, but it's more of a psychosocial complexity, dealing with the patient as a whole, dealing with all of their issues that they have when they step outside of your clinic room. It can get quite overwhelming. As Jan said, I want to try and make it as interactive as I can, understanding though that we have some limits based on the virtual nature of this. I have incorporated some poll questions into the presentation as well, so hopefully that'll allow us to interact a little bit. And the poll questions are anonymous, so don't feel shy to answer those questions. Before I proceed, though, I kind of want to get an idea of the audience. So if you could start off doing our first poll question, which I want to kind of know, what profession do you work in? And I'll give you a few minutes to answer that question. What is your primary profession? Okay, lots of dietitians. I'm happy to hear that. Wonderful. Physicians, RNs, few nurse practitioners and physician assistants. That's great. Okay, of those, the next poll question is, how much time during a typical 40-hour-a-day week do you spend providing direct patient-related care, be it education or actual clinical care, psychological care, whatever it may be? Well, that's great. Very good. Okay. 0 to 20% is probably the most, so that's okay. All right. All right, well, I'm going to go ahead and move forward here to our next slide. This is kind of my favorite slide. This sums up my perspective on diabetes management. I see diabetes management as an art. You use the science, you apply the science, but there really is no cookie-cutter approach to treating diabetes. You can focus on the medication, you can focus on the continuous glucose monitors, the diet, the exercise, but if that's all you're focusing on, you're leaving out a big piece of the puzzle. You have to look at the whole person. Each patient that presents to the diabetes clinic or primary care clinics for that matter are unique. They come to us with a set of characteristics, behaviors, beliefs, traditions, life experiences. We have to incorporate all of those characteristics into how we tailor the plan of care for those patients. That's where the art comes in. How creative can you get to get this patient to meet their goals with all of these characteristics that they bring to the table? You take the science, you massage it a bit, and you help the patient come up with a set of goals. Now, how do you do that? Because as we know, seeing patients is very time consuming. If the clinicians out there are anything like myself, I'm always running behind. I have 10 minutes to see the patients. I have my schedule is always overbooked. So when the patient gets into my exam room or any other exam room for that matter, As a diabetes clinic, what am I focusing on? I'm focusing on the blood sugars and the blood pressure and the cholesterol. It's a challenge. It's a challenge to go beyond that and look at the whole person. Does this all sound familiar to everyone? I hope it does. But, you know, back to the basics. I'm going to review this slide, and please know that this is nothing that you haven't heard already, but it's a friendly reminder to you as well as myself that these things are important, and we tend to overlook them a lot in clinic because we're running fast, always behind and running fast. But these characteristics on this slide, or these assessment areas, really shape how you're going to treat the blood sugar, the cholesterol, the blood pressure, and whatnot. So we're going to assess the whole person, both, well, not both, but all, spiritual, cultural, emotional, social, as well as physical. So you're going to look at the blood pressure, but you're going to look at why. Why is it elevated? What are they doing outside? You need to prioritize the care. What's important to the patient? Not important to us per se. Obviously, we do have to address the issues. We have to address the critical values and whatnot. But what did the patient come to you for? Assess and address health disparities. This can take a long time, and this may not be done in all one visit, as we all know. But are they food insecure? You know, how many times you have a patient come in the exam room and you say, okay, I want you to eat, you know, 3 fruits, 4 vegetables a week, blah, 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 and they can't access any foods. So your great plan of care is not tailored to that specific patient. Do they have a roof over their head? You know, do they have a car to get to the appointments or any sort of transportation? Do they have health care insurance? What are their cultural sensitivities? Do they have clean water? What is their education level? Those are all really, really important things when you develop a plan of care. Obviously involving the family, if they have a family, and who is their family. Establish a healthy, trusting rapport with the patient. Every single patient that comes to see me, I always tell them 90% of the care is in your hands. I'm just a cheerleader. I have just 10%. What I do in my clinic is help you do what you need to do to feel better, okay? Involve the patient in establishing the plan of care and setting their goals. It's all about empowering the patient. If they feel that they're involved, if they feel that what they're doing is making a difference, they're going to be motivated to, hopefully be motivated to do the right thing. And it doesn't work with every patient, but it does with a lot of them. Assess the readiness to learn and readiness to provide self-care. If they are not ready, you can beat your head on the wall, nothing will happen. So you really have to be tuned into this. And if you set up a visit to do diabetes education and you sense that they're just not into it, do something else, okay? Practice active listening, which is very hard in the days of computer or electric EHRs. You know, I find myself looking at the computer and asking questions and not making contact. That's not active listening. So I really have to force myself. And it really makes a difference with establishing a rapport. And most importantly, individualize the care and set realistic goals. This is where the creativity comes in. Know when to be more stringent or less stringent with treatment goals. Now, this is challenging. However, if we use, on the next slide, the American Diabetes Association has set up this really cool chart for us that lets us, kind of guides us a little bit as to some usually not modifiable risk factors and potentially modifiable risk factors to help us set the hemoglobin A1C goal. You have to individualize care, and some of the criteria on the left-hand column here can help. You know, if the patient is has no family at home, they live by themselves, and they have a history of frequent hypoglycemic events, you're not going to want to set the goal at 7% with this individual. If the patient is elderly and has and is taking care of his or her wife, you know, 9 times out of 10 that the A1C level should not be set at 7, more between like 8 and 9, not closer to 9, but more like 8, 8.5. I think you kind of get the message. But if we look at the disease duration, life expectancy, relevant comorbidities, complications, and what is their attitude and expected treatment efforts? Do they care? Are they motivated? Are they doing self-care? All of these criteria make a difference in how we approach the setting realistic goals. Okay, so I'm going to go ahead and get into my first case. And I know that you're able to read this, but I will read it to you. This is JT. He's a 70-year-old American Indian male that presents to the clinic with his wife for diabetes management. Diagnosed with type 2 diabetes 10 years ago. He was initially treated with diet and exercise for the first 3 years and now is taking pills. He's typically managed by his primary care provider but hasn't seen her in a while. He lives with his wife and is currently unemployed. Reports that he has a glucose meter but only checks his blood sugar when he doesn't feel well. Reports excessive thirst and frequent urination, going about 10 or more times a day. Reports that he doesn't exercise and eats whatever there is available in the house. Does this sound familiar to you? This is a very common scenario right here that you often see or hear both. Okay, the history and physical. His medical history, he does have a history of cardiovascular disease. He had a stent placed in 2003. He has been following with a cardiologist. He does have hypertension, retinopathy, and peripheral neuropathy. These are his medications. Okay. Recent labs. Okay. You can see here that the blood sugars are not being very well controlled. Okay. And the cholesterol the profile is not terrible, but it's really not the best. We've got some issues going on. Okay. All right. So, I'm sorry. More physical exam findings. He does have a systolic murmur, large habitus, decreased sensation in his feet bilaterally. His blood pressure's up a bit. His BMI is 35, and the point of care testing, his blood sugar was 285 and hemoglobin A1C 10.8%. All right, moving into a poll question here. Based on the information presented now, how would you proceed? So I'm going to go ahead and advance my slides because it kind of says the same thing. Would you stop the glipizide and immediately start a basal bolus insulin regimen? This is not a bad thought because the hemoglobin A1C is 10.8% and his blood sugar is 285 and he is symptomatic. Would you add a DPP-4 inhibitor to his current regimen? Not a bad thought. I mean, his blood sugars are elevated. Enroll him in a weight reduction program and have him come back in 6 months. His BMI is 35. Counsel him about his poor lifestyle habits and set him up for self-management education classes. Or 5, obtain a more in-depth history, not enough information to develop a safe and effective plan of care. Yay! That's the answer. The 1 through 4 is not necessarily wrong, okay, but it's important that we learn about this gentleman. There were some red flags in his history, so it's important that we proceed to find out more information. Okay, so what other components of the history would be helpful to obtain at this time? All right, here are some things. Now, there's a question in the comments section, how often do you miss sulfonylurea? Absolutely. That is, medication compliance is definitely a question that we would want to know about. And that is the first bullet here. So to just kind of give you a little bit of background of this patient of mine, his medication compliance was overall pretty good. Food availability, eating patterns, and nutritional status. He told me that he consumes 1 to 2 meals per day. He is on a fixed income and can't really do much more than that. Check about his relationship with his significant other and other support systems. This gentleman lives with his wife. She has Alzheimer's disease, has had it for 5 years. She needs 24-hour care, and he is the primary caregiver. So that could be an issue. Employment, financial situation. He's laid off, he's unemployed, laid off and unemployed. I'm sorry, nothing more there. Substance abuse, he denied. Needle phobias, he really doesn't want to use insulin, but will if he needs to. Preconceived ideas of diabetes and treatment of hyperglycemia. He knows he has the bad diabetes because he knows he needs insulin. How many times have you heard that? I've got the bad diabetes because I'm on insulin. You have to dispel those myths when you see the patient. Does he have access to care? Does he have insurance? And he does have Medicare. What are his spiritual and cultural beliefs? He didn't expound on that much. He does have a car. And as far as history of anxiety or depression, he says he feels a little bit down, but he's denying depression at this time. Are there any other areas that we've missed that are important to kind of find out before we establish a plan of care? I'll give you just a second if you want to put it in. Is he eligible for congregate meals? Yes, right. Is he eligible for that? Absolutely. Anything else? I'm just going to give you just a few seconds here just to kind of type in. There are a number of things. Does he have activities he enjoys to be active or access to a gym? Yep. These are all wonderful, wonderful questions. Any more that you can think of? And when we, I'll give you a minute just to type into the comment section, but when we move on to the next screen, I'm going to help us establish a plan of care, but keep in mind this, there's no real right or wrong answer to this. This is what I did in my clinic. That doesn't mean that this is the be-all, end-all, and that if you did something else, that it would be wrong. And with that said, again, as you're doing now, type into the chat box if you think that I've missed something in the plan of care that you feel should be there. So, ACEs, is he on ACEs? Yes. How far does he live from the health facility? These are great questions. Does he get home care at all for him or his wife? Does his community provide respite services such as the Title VI program for caregivers, mental health, and hemoglobin A1C target? I would not want to go any lower than 8% for this individual, knowing that he is an elderly man taking care of his wife full time, essentially spends a big part of his day by himself. Okay. I started Lantus, educate on insulin, injection technique, proper identification and treatment of hypoglycemia, and advise to monitor glucose twice a day. I discontinued the glipizide and continued metformin at 1,000 BID. I started an aspirin, and we'll talk a little bit about that in a minute. Got him enrolled into some diabetes education classes. Put in a referral for nutrition counseling and social work services. I advised him to walk a little bit, 10 minutes every other day. I always start at that point. Seems like everybody's kind of willing and able to do that little bit, and then they work up from there. Screen for depression and referral to psychotherapy if needed. Oral retinal exam and a lab profile. Anything that I missed, type it into the chat box. While you're typing, I'm going to go ahead and move on to the next slide. Okay, and this little chart here is taken from the glucose management and type 2 diabetes algorithm on the Division of Diabetes website. This is step number 3. Step number 1 is set realistic hemoglobin A1C goals, which we have. Step 2 is to initiate medicine, which he's already been on. Step number 3 is here, increase the dose or add another medicine. Now, I chose to, see if I can do this here. I chose to add insulin therapy because I can't get the little pointers. There we go. I chose to add insulin therapy because you get the most bang for your buck here. His hemoglobin A1C is greater than 10%. He's having signs and symptoms of hyperglycemia, and it's kind of a cheaper medicine. So, well, cheaper than some of the others. However, we could have started other things. Because his hemoglobin A1C was greater than 10, that's why I chose the insulin therapy. There are other options here. Okay. Now, when I started the insulin, as you know, I started 10 units at bedtime. There are two ways you can do this. You can go by units per kilogram per day, or just start with a common 10 units at bedtime and see how they do from there, and increase based on the morning blood sugars or the fasting blood sugars. I'm not going to go over this chart. There's lots of words here, but I will tell you that this is also one of our algorithms. It's the insulin algorithm on the DDTT website. So the reference is there if you're interested in taking a look at that. Okay, and I did start him on 81 milligrams of aspirin. Now, this is for secondary prevention. This individual has a history of coronary artery disease, and he had a stent placement in 2003. And according to the guidelines, that is what you do. So here are the guidelines. Okay. Now, patient does all that stuff and comes back six months later. So, comes into the clinic for a 6-month checkup. He has been seeing the provider every 1 to 2 months to make adjustments to his medication regimen. He's now taking 20 units of Lantus at night, Aspart, 6 units with breakfast, 8 units with dinner. He reports compliance with his medications and has been monitoring his glucose 2 to 3 times a day before meals and or at bedtime. He arrived with his blood logbook and meter to his visit, and he reports no signs and symptoms of hypoglycemia. What a perfect patient, huh? They were only all like this. Physical exam was quite unremarkable. Blood pressure 136/86. Pulse is fine. His BMI is up at 35. A1C is down to 8.1%. Wow, very nice. 8.1% blood sugar 140, and this is a random check. This is outstanding. So, going on to a poll question from here. Oh, labs were normal, sorry. Based on the information presented, how would you proceed? Patient is almost at his A1C goal and denying signs and symptoms of hyperglycemia. Maintain current medication regimen, reinforce diet and exercise, make him come back in 6 months for a checkup. Or enroll the patient in a weight management program, have him come back in 6 months. And weight management and have him come back in 6 months. Analyze his glucose log, identify patterns in the values, obtain a more in-depth history of his lifestyle behaviors, and change his medication regimen. Outstanding. You guys are good, really good. Consider adding a GLP-1 receptor agonist to his regimen. Okay, it's split. However, number 1 is a little bit more than number 3. Oh, it's growing. I'm going to give you a few more minutes on that one. The answer that is typically given for this question is number 1, okay? However, if you choose number 1, you may be in trouble, because if we analyze the glucose log and identify patterns in the values, this is what you're going to see. Now, this is not good. This is not good for anybody, but more importantly, for an elderly individual that is taking care of an Alzheimer's patient at home and trying to take care of himself as well. This is a problem. But this shows you the danger or the risk of just going strictly by the hemoglobin A1C. Hemoglobin A1Cs take all the numbers together, they average them out, and they give you a percentage, as you know. And if we did that, all of this comes out to 8.1%. However, the patient is in danger. So what at this point should we be assessing? What types of questions should we be asking? Dan, you can take the poll down and the comments can come back up. Comment section. Thank you so much. What kind of questions should we be asking at this point? Are you having lows? Okay, he denied lows. Well, he denied hypoglycemia, but he didn't deny actual lows. Timing of the insulin, when and how often, what, when, how, and why. That pretty much sums it up. Thank you. Definitely. What is he eating? Is there food available? Is he skipping meals? Because it looks apparently like he may, I can't grab that little arrow. He may, uh-oh. Jan, I lost the screen.
Hold on, I'll get you back.
Okay, so some of the comments are when and how often, what, when, how, and why, medication adherence, exactly. What are you eating for dinner? Do you include snacks during your day? All of these are very important. Is he skipping meals? Is he exercising real hard one day to maybe cause a low blood sugar reaction? But really important is, how is he injecting his insulin? Is he doing it correctly? I had a patient one time that came in with high blood sugars every single visit. I kept increasing the dose and increasing the dose of insulin. And come to find out, when I had him show me how he was injecting, he wasn't tilting the syringe upside down or the vial upside down. He was pulling air into the syringe and injecting air in, and he wasn't getting any insulin. So insulin technique is really, really important, especially for someone that's just learned how to do this. Overdose on insulin, absolutely. Check technique and the dosage, absolutely. Thank you, Jan. I don't know if this is something that I did or.
You probably hit stop sharing when you were trying to turn on the.
I can advance it if that's okay.
Yep, I've got it. I think I'm back to.
Yep.
There you go.
Perfect. That's perfect.
Okay.
Thank you so much.
Thanks.
Okay, I think we're ready to move on. So we know that this individual is kind of, the scenario was a little bit risky, and we needed to definitely address those lows. So moving on to case number 2. This is a female patient, 52 years old, American Indian, that presented to the clinic for diabetes management. She was diagnosed with type 2 diabetes 5 years ago. She was initially treated with metformin and is now taking metformin and glipizide. She's currently unemployed and states that she lives with her sister and her sister's husband. She doesn't have a car, so she relies on her friends for transportation. Reports that she doesn't have a glucose meter and only takes her medicine when she has them. Reports that she doesn't exercise and eats whatever there is available. History and physical, she does have hypertension, has a history of intermittent alcohol abuse times 20 years, drug abuse, last used heroin 3 months ago, tobacco for the last 20 years. These are the medications that she takes sometimes. No labs on file. Blood pressure is a little bit elevated. BMI is 30, and her A1C is 9.5. Does this look familiar? Okay, moving on. Okay, another poll question here. Okay, and let me just set the stage for just a minute. You've got 10 minutes. Well, actually, it would be 20 minutes for a new patient. 20 minutes to see this patient. This is all the information that you have. Based on that, how would you proceed? Number 1, counsel the patient on medication compliance, provide a glucose meter with instruction, schedule her for a visit with a dietitian, and have her come back in 3 months. That's not so bad. I mean, she takes her meds intermittently. She could use a little bit of diet instruction, maybe. Not a bad choice. Number 2, increase the glipizide to 10 milligrams twice a day, provide a glucose meter, and advise her to monitor twice a day. A1C is 9.5. She definitely needs some intervention. Enroll her into a weight management program and diabetes education classes and have her return in 3 months. BMI is 30. This definitely would be helpful. Maybe not right this moment, but definitely would be helpful. Or number 4, screen her for depression, explore her living arrangement in more detail, assess for food insecurity, and order a full metabolic lab profile and a glucose meter. So this one's kind of straightforward. Number 4 is definitely something that we would do. I don't feel that we have enough information to proceed based on what we have, so we do need to get some more information. Okay, so what additional information would be helpful to develop an appropriate plan of care? If you want to type in the chat box, I'm interested to hear what everyone has to say about this. What types of questions would you ask at this point? Meal education, portion control, absolutely, absolutely. Anything else? Just want to give you a few minutes. Complete an SDOH assessment, sure. More about her substance abuse, perhaps, absolutely. 1 to 10 change scale, motivational factors, yes. Domestic violence or any current experience of trauma, perfect. How much alcohol, how often, do you live alone? These are great. These are absolutely great. I love it. Talk about the environmental factors. Okay. After further discussion with AB, she disclosed that her living arrangement is not stable. She she visits shelters and stays with her sister when she is allowed. She has a difficult time getting food but relies on friends and family to help her. During the discussion, AB became tearful. And her patient health questionnaire, or PHQ-9 score, was 12. What does that mean? Okay. So I'm going to try and do this again. Let's see. I can't grab I can't grab that little arrow. I've been trying, so let's not use it. Okay, so as you can see, with a PHQ-9 score of 12, she fits into the minor depression, dysthymia, or major depression mild category. So some of the treatment recommendations: support, watchful waiting, antidepressants, or psychotherapy for both of them, dysthymia and major depression. Do we want to jump to this immediately? Probably not. More assessment needs to be done, but there's definitely something here that we cannot ignore. She does deny a history of depression, but yet obviously something is going on here that we cannot let go. So what would your plan of care be now? Now keep in mind, this individual is here for diabetes management. The consult said diabetes management. She's in your diabetes clinic. Is it the right time to address her diabetes? Do you think that that is, speaking of readiness to learn and readiness to listen, do you think that that is a reasonable approach at this time? I would say not. You know, not having secure housing, not having, you know, secure food, those are things, and when I say complex patient cases, this is what I mean. I mean, where do you go with this? You need support services. Social worker, food stamps, absolutely. You all have really, really great ideas. Substance abuse, depression, mental health services referral. I got her into mental health right away. Number 2, unstable housing, put a social work referral in. Food insecurity. There's a wonderful food insecurity resource tool on the DDTP website that any of you can access and use in clinic. It's really, really helpful if you want to do that. And number 4, diabetes. We're going to put this on the back burner. We're going to make sure she's not in any harm's way, but continue the current regimen for now. Encourage her to take her meds, refill her meds, and order a metabolic panel. All right, she comes back 6 months later. Presents to the clinic for her 6-month diabetes management visit. She's been following up with her social worker and mental health provider and has secured stable housing, is being treated for depression and anxiety and is enrolled in an outpatient drug rehab program. She reports improved compliance with her medications, is getting food from local pantries and churches, and is currently seeking employment opportunities. These are her medications, and you can see here she obviously has been placed on something for her depression and anxiety. Here are her labs. A1C is a little bit lower, I believe, at 8.9%. Lipid profile is not beautiful. Okay, blood pressure. Point of care testing is 9% for her hemoglobin A1C and blood sugar at 135. Okay, is it time for the diabetes management now? Now we've addressed the psychosocial aspect of her care. Well, the biggies, let's put it that way. I don't think we ever address all of them, but we've addressed the biggies. Now it's time to focus in and hone in on her diabetes a little bit closer. What types of things would we do? In the chat box. Refer her to social work. Oh, I think that was an older one. What types of things can we do now? Diabetes related, focused. I'm just going to give everyone a minute to type. I'll go ahead through my bullets here, and then any additional ones we will bring up that aren't on the list. So again, I chose to increase the glipizide to 10 milligrams twice a day, but please do know that there are other medications that can be added, such as a SGLT2, DPP4, and others. Educate her on healthy eating and food preparation. Refer her to, these are in the comments, refer her to an RD, CDE. She may be ready for diabetes management classes. However, these classes could be helpful while she is in outpatient drug rehab meetings. Perfect. See how creative people can get with these plans. I love that. And I learned so much from the comments. Consistent meal patterns, utilizing My Plate. Beautiful. Medication adherence, stress management, talk circles. These are wonderful, wonderful recommendations. Second thing on my list is start aspirin, and we'll talk about why in just a moment. Dispense glucose meter and supplies and advise monitoring 1 time a day, varying the times. Refer for nutrition counseling and diabetes education, I think, which was below. Encourage 10-minute walking every other day and increase as tolerated. I told you that's kind of something that I always do with the patients if they're not. Advise smoking cessation. Refer her to cessation counseling if needed. Is she ready? Because if she's not ready and tells you straight up that she's not ready, it's kind of a waste of time to refer her at that point. And maybe a CHR referral is needed. Oops, okay. Okay, some of the responses below, let's see, look at her blood pressure, yes. Discussions around exercise, invite her to groups within the clinics, perfect. Provide resources to community food kitchens, yes. Excellent, excellent, excellent ideas. I love it. Okay, moving forward. What is an appropriate plan to treat her hyperlipidemia? Now, as you know, she's had hypertension for 10 years. She smokes, she drinks, and she's 52. So if we take a look at the algorithm here for lipid control, again, the lipid and aspirin therapy algorithm is posted on the DDTP website. Most of my resources that I've used in this presentation are taken from there. So if you want to gather any of those, just visit the link on my slide. The slides are available to you. So hypertension times 10 years, that's a risk factor. Alcohol use is a risk factor. Smoking is a risk factor, and she's 52. So it looks like she falls right into this category here. She does not have cardiovascular disease that we know of yet, but she does fit into this category. She is currently taking simvastatin 10 milligrams a day. Is that a high intensity? It is not. So the statin medications that are high intensity are here, okay? Atorvastatin or rosuvastatin. Either of those would be helpful for this individual based on her risk profile and her age. Okay. Okay, what's an appropriate plan for her blood pressure? Right now, she's not taking anything. Her blood pressure was 140/95 at 2 different visits, and she has no albuminuria. And I just wish I could get this little arrow to work. I'm going to try one more time. Okay. All right. So if you look at, excuse me, if you look at the left-hand side of the algorithm, initial blood pressure less than 160/90, which it is, we're going to proceed to lifestyle management, which we have, and start one agent. Does she have albuminuria? No, she doesn't. Oh, great. Thank you. Thank you for that. I think that's Jan, maybe? I don't know. Whoever's doing the arrow, thank you so much. She does not have any albuminuria, so it is safe to say we could start one of the drugs in the box below. And again, this is just a portion of the blood pressure algorithm taken from the standards of care from the American Diabetes Association. So if you want the whole algorithm, you'll have to kind of take a look at that link. All right, I think, oh, I love this final one. Dear Diabetes God, please bless us with good blood sugars today. You know, this is a funny picture, but it's really, really true. I have patients tell me all the time, well, you know, they'll come in with a perfect blood sugar, yet their hemoglobin A1C is 10.5, and they'll say, well, gosh, I wanted it to be perfect for you, so I didn't eat anything yesterday. So this is the type of scenario that we see in clinic. They want to please you. They want to make it perfect when, in fact, you know, there's obviously interventions, more interventions that are needed to proceed. Some of the comments below is start an ACE and an ARB, absolutely perfect for the blood pressure. You're right. Mr. Stringham says your arrow was working. Gosh, it wasn't moving on my screen, so thank you for that. Would you recommend that she receive a home blood pressure monitor and monitor her blood pressure at home? Absolutely, positively. I try to give all of my patients one of these. However, again, you have to determine if they're going to use it. If they're going to use it, I definitely prescribe one for them. ACE and DASH meal plan considerations, absolutely. These are all great suggestions. Oh, thank you, Jan. Jan has put up the screen for food insecurity assessment toolkit. Wonderful tool that I use in my clinic all the time. All right. That concludes my cases. I'm happy to take questions or any other comments. Anything that any of you can add to those 2 cases, I'm definitely all ears. I'd like to hear. And like I said at the beginning of the presentation, I learned from you all as you learned from the presentation. So please share what you have. This is wondering what your thoughts were on the 81 milligrams of aspirin. I sure did say that, didn't I? That I would talk about that. I want to bring up, I thought I had a slide in here about aspirin. I started her on aspirin because as primary prevention, wait a minute, let me scoot back just a second to that aspirin one. Sorry guys, I didn't want to make you dizzy here. Oh, here it is. Okay. So if you take a peek at the aspirin thing for primary prevention, consider aspirin in patients with increased risk. Okay. She's definitely at increased risk. More than 50 years of age. If they are not at risk, if they're, geez, I'm tripping over my words here. If they are not at increased risk of bleeding. So she definitely has risk factors. And definitely over the age, she is 52, so that is why I considered putting her on aspirin every day as primary prevention. I hope that answered your question. Can you speak to Lantus versus Levemir versus newer long-acting? My experience with the newer long-acting agents is that some of them just don't last 24 hours. I've had better luck with Lantus, but there are some patients that Lantus doesn't last 24 hours either. I tend to kind of go with what's on formulary at the time, and that's why I always select Lantus, but I don't have any opinion as one being better than the other, just the duration of action. So I guess I can't comment too much on that. Super awesome. I like the art and science. Thank you so much. What were the evidence-based interventions? The evidence-based interventions were the lipid treatment, the blood pressure treatment, the hemoglobin A1C treatment, that sort of thing. Does your faculty adopt an algorithm for standardized diabetes management? The algorithm that I tend to use is the VA algorithm. However, we have a beautiful algorithm on the DDTP website that's also very, very helpful as well. Continuity becomes an issue, absolutely positively. The no-show rate of these types of individuals that are suffering from these psychosocial issues is really, really high. So trying to get them to come back based on lack of transportation and the drug use and that sort of thing is very difficult. And I think that's where the complexity comes in, and that's actually where the creativity comes in too. I mean, what does it take to get these folks to come in? Oftentimes, that's when you ask the questions, what can I do for you? They're oftentimes not interested in a pill for my blood sugar or a needle for my blood sugar or a pill for my blood pressure. What can I do for you? I'd like some food or that sort of thing. So, I mean, you have to, like I said, I can't stress it enough. You have to be as creative as you can. Jan has posted the algorithms on the website, which is great. How do you address diabetes distress or burnout? Well, I wish I had an answer for you, actually. Are you talking caregiver distress and burnout, or are you talking provider? Because I've witnessed both. When I did do diabetes management Monday through Friday, every single day, every week, the burnout got outrageous. And you just have to step away. As a provider, you just have to step away. You have to do something different because ultimately it gets to the point where the burnout gets bad enough that you're not helping the patients anymore. You need help yourself. And as far as the caregiver burnout, that's where social work comes in and getting respite care and that sort of thing. Patients distress burnout of caring for themselves. Oh, right. But also caregiver burnout. The patients need to understand, well, I shouldn't say need to, the patients try and help them understand to take one step at a time. All of that stuff that I presented in the case presentations does not have to occur in the first visit or even the second or third or fourth visit. It takes one visit just to establish somewhat of a rapport, let alone that laundry list of things. It's important for them to understand that the changes that you make today have to be lifetime changes. So when patients come in and tell me, my goodness, I haven't exercised in 10 years, but I'm joining the gym and I'm going to start this weightlifting program, and it incorporates like a 4-mile run every day. And I mean, you have to be realistic with your goals. That's when you step in as a provider and say, okay, back up for just a minute. This has to be a lifetime change. 10 minutes of walking slowly every other day and increase from there. Take one day at a time and take one issue at a time and try not to look at the bigger picture initially. Small goals, absolutely, Anna. Small goals are